Hello everyone, welcome to this online course on ophthalmology. I am Dr. Huang from the Joint Santo International Eye Center, the JSIEC. This section will focus on posterior uveitis. Through this section, you are expected to explain the anatomy, pathology, clinical features, diagnosis, as well as the management of posterior uveitis. Before class, I would like to share you a case. A 35-year-old woman presented with bilateral progressively visual loss for 1 month. She had a history of tinnitus and vertigo for 1 year. OCT scans show a multifocal detachment of the sensory retina. What has happened to its eye and how to deal with it? I hope that after this course, you can perfectly answer all these questions. Now let's begin the course. The uvea is the vascular layer of the eye and is made up of the iris, ciliary body, and choroid. We have already gone through anterior uveitis in the previous section, and today we will concentrate on posterior uveitis that involves the fundus posterior to the vitreous base, as well as panuveitis, meaning involvement of the entire uveal tract. Posterior uveitis comprise retinitis, choroiditis, and retinal vasculitis. Some lesions may originate primarily in the retina and choroid, but often there is involvement of both. Retinitis may be focal, multifocal, geographic, or diffuse. As you can see in this fundus, active lesions are characterized by a whitish retinal opacities with indistant border due to surrounding edema. And choroiditis can also be focal, multifocal, geographic, or diffuse. This photo shows active choroiditis characterized by a round yellow noodle on the fundus examination. Vascularitis may occur as a primary condition or secondary to adjacent focus of retinitis. Both arteries and veins may be affected, although venous involvement is more common. Please note here a yellowish or great white patchy perivascular cuffing in a patient with acute vasculitis. We may also see retinal hemorrhage. Presentation of posterior uveitis varies according to the location of the inflammatory focus or the presence of vitriasis. For instance, a patient with a peripheral lesion may complain of floaters, whereas someone with a macular lesion will predominantly present with impaired central vision. Posterior uveitis can be roughly divided into two categories: the non-infectious and infectious uveitis. The etiology of posterior uveitis is diverse and complicated. In the following slides, I will show you some typical examples. The Vogt-Koyanagi-Harada syndrome, also known as the VKH, is an idiopathic multisystem autoimmune disease featuring inflammation of melanocyte-containing tissue such as the uvea, inner ear, and the meninges. In practice, VKH can be subdivided into Vogt-Koyanagi disease, characterized mainly by skin changes and anterior uveitis, and Harada disease, where we predominantly see neurological features and executive retinal detachment. The VKH has 4 phases of progression. The prodromal phase lasts a few days, is characterized by a neurological and ordinary manifestations. The patient develops headache and a stiff neck, tinnitus, vertigo, and deafness. Encephalopathy is less frequent and may exhibit as convulsions, paresis, and cranial nerve pulses. Acute uveitic phase follows soon thereafter and is typified by lateral granulomatous anterior or multifocal posterior uveitis and exudative retinal detachment. We then have a convalescent phase several weeks later and can find patchy hair loss, graying, and depigmented skin and the sunset growth fundus. In the final chronic recurrent phase, the patient has smoldering anterior uveitis with exacerbations. Posterior uveitis occurs in patients with Harada disease and is frequently bilateral. You may find a diffuse choroidal infiltration and papillitis, multifocal detachment of the sincere retina, and disc edema. The chronic phase shows diffuse retinal pigment epithelium atrophy called the sunset growth fundus, which may be associated with small peripheral atrophic spots. For VKH treatment, we need to use high-dose oral prednisolone, sometimes even with a 3 days intravenous methylprednisolone pulse therapy. Patients who are steroid resistant or have recurrent uveitis may require cyclosporine. Sympathetic ophthalmitis is a bilateral granulomatous panuveitis occurring after penetrating trauma, often associated with uval prolapse. And less frequently, sympathetic ophthalmitis can develop following intraocular surgery. The traumatic eye is referred to the exciting eye, and the fellow eye, which also develops uveitis, is the sympathizing eye. Since histological proof is frequently lacking, the diagnosis is mostly presumptive. In 60.5% of patients, this condition develops between 2 weeks and 2 months after the initial injury, and 90% within the first year. Treatment includes steroids and psychopragic stimuli to other posterior uveitis. We often need to treat for at least 1 year with gradual dose tapering to reduce the risk of relapse. Prevention is more important. Repair the penetrating injury as soon as possible with antibiotics may help to reduce the development of sympathetic ophthalmitis. Enucleation within the first few days following trauma should be considered only in eyes with a hopeless visual outcome. The exciting eye may eventually have better vision than the sympathetic eye. Also, evisceration does not seem to protect against sympathetic ophthalmitis. Symphytic uveitis is caused by the spirochete bacterium Tamponema pallidum. The acute posterior choroidal retinitis is often multifocal and bilateral. Examination reveals large, solitary, placoid, pale yellowish subretinal lesions in both eyes. Retinal vasculitis may be occlusive and involves both arteries and veins. Treatment is the same as for neurosyphilis, with intravenous penicillin G for at least 2 weeks. Uveitis is sometimes associated with immunosuppression. The cytomegalovirus retinitis is the most common opportunistic ocular infection among patients with AIDS. Indolent retinitis frequently starts in the periphery and progresses slowly. It is characterized by a mild granular opacification, which may be associated with a few punctate hemorrhage spots. We can see dense, white, well-decorated geographical areas and confluent opacification often together with retinal hemorrhage. Parasites can also cause posterior uveitis. Common pathogens include Toxocara and Toxoplasma. Toxocariasis shows a scar at the fovea and a fresh lesion involving the papillomacular bundle, while toxoplasmosis forms a solitary inflammatory focus near an old pigmented scar. Occasionally, we can even see leaf worms in the fundus. To summarize, posterior uveitis complicated with its multiple and variable etiologies and clinical features can sometimes make definitive diagnosis rather difficult. Therefore, medical students and junior doctors should learn more about uveitis and its related systematic disorders, and remain vigilant when evaluating patients in order to avoid a misdiagnosis and delay management of posterior uveitis. Here are the references. Thank you and see you the next time.